Good morning, good afternoon, everyone. Thank you very much for joining this very exciting session. We are going to give a few more minutes for other colleagues to join, and then we'll get started. Whilst we wait for them, please introduce yourself by giving us your name and your organization and the country you are joining us from in the chat box. Thank you. Good morning, good afternoon. Welcome to the first CQUIN webinar in 2025. And this is really taking place at a very consequential time in the history of HIV treatment program. So thank you very much for making the time to join us in spite of your very busy schedules. Today's webinar is going to focus on sustainability, resilience, and emergency response, and discuss some case studies on how countries are responding to the interruptions in HIV funding. Next slide. So my name is Peter Perkun. I am the CQUIN project director and the PI, and it's my pleasure to co-moderate this session with my colleague Peter Rinkrans, who I will introduce very shortly. So please be sure to select your language of preference. We will have simultaneous interpretation in French. So use the globe at the bottom of the screen to select your language of preference. Next slide. So this is going to be a 90-minute webinar. We'll have framing presentations followed by facilitated discussions and Q&A. As presenters present, if you have a question, please put it in the Q&A box and they will respond to them in real time after their presentation. But at the end of the presentations, we will also have live Q&A and you have opportunity to ask more questions. If you want to speak at that point, use the raise hand function on the toolbar and we will unmute you so that you can speak. If you're a French or English speaker, please ask your question in your language of choice and the interpreters will translate as needed. I also want to remind you that all recordings for this webinar will be on the CQUIN website. The address is below. Next slide. So in 2023, CQUIN initiated a stream of work on integration, which culminated in an all-member country workshop in April 2024 on integration. Following that, at the CQUIN annual meeting in December last year, we also focused on concepts around person-centered services as well as sustainability. And I want to believe that these activities that were initiated last year have partially prepared us, for the situation in which we find ourselves today. So today, as I mentioned earlier, we are going to discuss sustainability and the emergency response countries have taken to ensure that their programs are very resilient. And we have three definitions here on these topics. So sustainability, as we all know, is the characteristics of a health system that enables ongoing performance in the context of decreased external support. Whereas resilience is a national health system preparedness for and capacity to adapt in response to public health emergencies and other shocks. And of course, emergency response is a short-term response to health system shocks like we have found ourselves now. Next slide, please. At the annual meeting, we shared different definitions of sustainability. However, we emphasized the fact that within the network, our sustainability will be defined as effort to sustain the gains we have already made in the HIV response. So we have found ourselves in a situation where the gains we have made are being threatened by uncertainties in funding. And that is why we want to use this opportunity to share best practices and to exchange lessons from member countries, what emergency responses they have come up with, the discussions and deliberations that went on to inform the prioritizations that they have made so that we can learn from each other. I'm in another country recently and right now, sorry, and they mentioned the fact that when we shared the emergency response from Kenya, when the PS saw it, immediately the PS said, "Oh, I want something like this." And so she charged them to develop something similar, which they were able to do quickly because one country has already done it. So this is the kind of rapid response and based on lessons from other countries that we really want to use this platform to push forward. Next slide. So, you all remember our experience during COVID time where, we used the CQUIN platform to really exchange lessons and adaptations that countries have made to sustain resilience of their programs during the COVID time. And in Mozambique, for example, the HIV programs were really found to be more resilient than the NCD programs in the face of events like cyclones and even during the COVID era. So really, when we talk about resilience, really what we want to do is to ensure that we are able to sustain our programs in the face of events as we have found ourselves. Next slide. So we have put together a very high profile, panelist to discuss the emergency response that the countries have made. And so we have countries from Malawi, Kenya, presenters from Malawi, Kenya, and Ghana who are going to share their country case studies with us. We will precede that with framing remarks from our colleagues from the South to South Learning Network. And then we'll have Q&A to drive home some of the conversations. Next slide. At this point, I would like to introduce some of our panelists, starting with my co-moderator, Dr. Peter Ehrenkrantz, who is the Deputy Director for HIV Testing and Treatment at the Gates Foundation. In the interest of time, I'm not going to read all the bios. So next slide, please. And then, as I mentioned, we have 4 presenters. Kerry Mangold is going to give us framing remarks, and she is the Program Director for South to South Learning Network based in South Africa. After that, we will have a presentation from Linley Cheweri, who is the Director of Care and Treatment, Ministry of Health, Malawi. So she's the Director of the Department of HIV and AIDS at the Ministry of Health, Malawi. Sorry about the typo on the slide. And then we have Dr. Andrew Mulwa, who is the head of the National AIDS and STI Control Program, Ministry of Health, Kenya. And then last but not the least, Dr. Stephen Eisiado, who is the program manager for the National AIDS Control Program, Ministry of Health, Ghana. Next slide. So I will now hand over to Kerry to give us her framing remarks. Kerry, over to you. And thank you.
Thank you, Peter. Thank you. And good day, colleagues. I think we can just go straight to the next slide, Laura, please. So the abrupt suspension of many HIV programs through the issuance of stop work orders threatens decades of progress in preventing new HIV infections. and ensuring access to HIV treatment, particularly in sub-Saharan Africa. So the South to South Learning Network, also known as the SSLN, rapidly engaged its network of policymakers and frontline implementers to try and sift through the chaos and gain insight into the immediate and longer-term implications of the stop work orders, as well as the contingency planning processes and considerations that countries are going through. And I'm sure many of you are part of this. Our findings from 14 countries who are members of the SSLN paint a picture of service disruption, funding gaps, and uncertainty at a country level. And what I'm hoping to do through these framing remarks is give you a little bit of insight from what we are hearing from our countries. Next slide, please. So this rapid assessment, and you must appreciate this is quite fluid and constantly changing, revealed 4 major short-term disruptions. The first is in the health workforce. So HIV focal points and managers, community health workers and data capturers are among many personnel within national AIDS commissions and ministries of health that have been historically PEPFAR funded, creating a capacity and resource gap to deliver services. And we've seen this in almost all countries. Nigeria is an example where this is playing out, but I would say this is relevant in all of the countries. Number 2, with supply chains, we are seeing stock shortages of ARVs, lab testing supplies, and prevention products like HIV self-tests as an example. And even worse, in some cases, we are kind of hearing about commodities that have already been procured that are sitting in warehouses and not being distributed. In relation to community outreach, key population programs and programs for adolescent girls and young women have shut down in many countries or are sitting in limbo, impacting comprehensive prevention and treatment programs, as well as demand creation for these programs. And also regarding data and monitoring. So there are disruptions in monitoring and reporting processes that we're hearing from countries, in strategic information capacity and monitoring systems. And really what this means is that decision makers lack accurate and real-time data right now to respond optimally to what's happening on the ground. And in addition, a number of SSLN countries, including Mozambique as an example, may need to revert back to paper-based record keeping and tracking, given the reliance on PEPFAR-funded personnel and systems to support mobile and digital data records. So the reality really is that these disruptions will reverse hard-won gains toward prevention and treatment targets. So in 2023, around 3,500 people will be newly infected with HIV every day. And this freeze, even if it remains temporary, will or already has had irreversible impacts on the trajectory of new infections. And I think it really places the world further off track in terms of reaching the 2030 agenda, which we were already going to struggle to achieve. Next slide, please. So the stop work order is reshaping HIV delivery across Africa, but we found that not all countries are impacted equally or the same. Some countries like South Africa have a strong domestic funding base. Other countries like Ghana, as an example, have a lower reliance on US government funding. And countries like Zimbabwe, on the other hand, are almost entirely dependent on donor funding. But regardless of the different situations and the different funding landscapes, I think what we have realized by gathering insights from these countries is that all countries face serious risks to HIV program sustainability as these services are being suspended. So if we look at 2 countries just in a tiny little bit more detail, so South Africa, as I mentioned, has the majority of its response funded through domestic resources. And they might be better positioned to absorb some of the shock. But I think even in spite of this, community-based programs, outreach services, and HIV prevention in particular have been disrupted. And this is putting populations, especially key populations, at risk. in the country with the biggest HIV epidemic. Zimbabwe, if we look at that, we know is heavily reliant on donor funding. And what we have heard from the country is that they are really facing immediate issues, including short supply of essential commodities, challenges in surveillance and data tracking, and shutting down of programs, as an example, for adolescent girls and young women. So I think we are realizing, you know, the impact is grave, even if the funding landscape is slightly different. Next slide, please. And I think we know that, you know, even with court orders being issued, even with waivers coming out all the time, and I think we are struggling in some ways to keep up with all the changes, we realize that the funding freeze still poses significant threats. And in spite of, or despite all of these issues being kind of put out, for the most part, this has actually failed to restart delivery in the countries. That's what we are kind of hearing from countries. And so what this also means, I guess, is that there are some longer term and systemic threats to the future of HIV programs. And the longer this goes, maybe the greater the threat becomes. So these include surveillance gaps, governance and capacity and coordination gaps, new product introduction is being stalled, and ultimately we are anticipating increased HIV infections and mortality. So if I go through each of those just in a little bit more detail, you know, in terms of surveillance gaps, we see that disruptions to, you know, data surveillance in countries like Côte d'Ivoire, as an example, may result in the country struggling to be able to track the treatment cascade or drug resistance or new HIV infections. If we look at governance, capacity and coordination, we've heard from our countries that a number of their core coordination structures and processes, including processes for sustainability planning, have halted. And countries like South Sudan and Botswana, as an example, are struggling with filling the gaps that have been left in terms of coordination and governance of the HIV program. If we look at new product introduction, I think we were all kind of anticipating the rollout of Cabernet and lenacapavir. And I think what we've realized quite quickly is that this is going to be stalled, and these programs are not going to be what our kind of reimagined prevention response looks like, at least in the medium term future. And then ultimately increased infections and mortality. So I think we can just assume, and I know some modeling has already been done on this, but with a reduction in prevention service delivery and treatment, we should expect a resurgence in new HIV infections. And this will really undo years of hard-won progress. But I think on the flip side, what we're also seeing is that there is also an emergency response that's taking place in terms of putting contingency plans in place. And countries are really trying to move from, you know, reactive space to a place where they're really reflecting on what's needed and putting plans in place. So Eswatini, as an example, has been really quick off the mark in getting a task team together and drafting a mitigation strategy. Same for Tanzania. We see that countries in the SSLN and CQUIN network are trying to focus and strategize and have hope, even despite the confusion and the disruption that they're experiencing in the countries. And while this might be a little piecemeal and looking at the short term for now, I think what we know is that there are many lessons, and I think Peter already mentioned this in his opening remarks. There are already a number of lessons being learned along the way. Some of them will be shared in this webinar, and many more will surely be learned and shared by the affected countries and for the affected countries who are experiencing the effects of the stop work order. Next slide, please. So I think looking forward, you know, there's recognition that, you know, multi-sector collaboration needs to be fostered. Domestic resources need to be mobilized. You know, public-private partnerships need to be considered, and countries can and will build resilient HIV responses beyond US government funding. I think, you know, we've already seen Zambia as an example, exploring options with private sector or looking at construction sector taxing and community development funds to help close the gap. And all of these ideas and learnings will surely be relevant to countries in the region. But no country should navigate this alone. And I think peer learning and joint solutioning and cross-country collaboration is really why we exist, and even why this webinar is taking place. So the South-South Learning Network and the CQUIN Network, who connects these policymakers and implementers, really want to take on a responsibility to support exchanging insights and strategies that will help us find solutions. And on this call, I think we know that we all need to kind of collaborate on new ways of thinking, innovative financing, different funding mechanisms, while also improving efficiencies in program planning. And I think it's high time that, you know, the opportunity is seized to look at how we can implement the most targeted, prioritized, efficient, evidence-based HIV programs. So if you go to the next slide, which is my final slide, I think I just want to kind of reflect, and maybe this is a call to action, but I think all of us here and all of us belonging to the various networks and finding ourselves in this space that's been affected by the stop work orders, have a responsibility really to advocate for evidence-based programs, to defend the programs that we know work, and to lobby for supportive and equitable policies, including looking at our own governments, I think, in helping find solutions. What we can draw on, I think, is some resilience in the sector. I think all of us probably have a personal story or journey where we've overcome some really difficult challenges and made big contributions in the sector. And I think, and Solange is on this call, but ITPC hosted a webinar last week. And one of the things she said is that crisis can be an opportunity. And I think it really is. So I suppose just as I close to say that, let's use this crisis to overcome all these challenges that we have already identified as countries, and to really push forward in implementing those contingency plans. So thank you. I think I will leave it at this for now, Peter. Thank you.
Thank you very much, Kerry, for that great framing remarks and for sharing the broad overview of what is happening across the network countries. For those of you who may not be aware, the SSLN is a sister organization, focusing on prevention, while CQUIN is focusing on treatment, and 60% of CQUIN countries are also members of SSLN, and that's why we are co-hosting this important webinar with them. All the issues that Kerry shared actually apply also to the CQUIN network countries. So thank you very much, Kerry. I'll now invite Elinle Cheweri to share the Malawi case example. Elinle, over to you.
Thank you so much, Peter. Good afternoon.
1 minute, please. One minute, second. So, Kerry, please, there are questions in the Q&A box for you. So, or I think some of the questions are in the chat box actually. So please, if you have questions, please put them in the Q&A box so that we will not miss them. Thank you. Lily, sorry, you may be speaking to a muted microphone.
No, I was not speaking. I was in fact waiting for you to give me a go ahead.
Oh, please, sorry, go ahead.
Okay, thank you. Good afternoon. As introduced, I'm Lynn Cheweri from Malawi. Next slide. Next.
Could you please get closer to your microphone? Apologies, we're having a difficult time hearing you.
Next slide, please. Okay, thank you. Just a brief background on how much we have been affected by the executive order. As a country, Malawi has about 861 facilities that are providing ART, and about 50% of these facilities are partner supported. And these partners are in highly in high burden areas, and they look after about 90% of the recipients of care who access the ART in the partner supported facilities. So it means only 10% get services in the non-partner supported health facilities. Next. Next. So as a country, after the executive order, the Ministry of Health, through the Secretary for Health, convened a meeting, an emergency meeting, and formed a task force to look into the way forward on how best Malawi as a country can continue offering the services without interruption. So a number of people were involved. Those included interdepartmental team within the Ministry of Health, the civil society organizations, and the National AIDS Commission. So the situation analysis was done to look at the effect of the supply chain, the effect of the executive order on human resource in service delivery, on diagnostics and service delivery, as well as HIV information management system. Next. So after the analysis, we saw how much we were affected in all the areas that were highlighted. Then also we looked at the interventions. After looking at the systems, we looked at the interventions. How much do they contribute to the reduction of HIV transmission? So we used the goals model that we used to develop our strategic plan. And we looked from the goals model, we saw that adult ART provision contributes about 63.1%, PMTCT 12%, VMMC 6%, condom use 17.2%, and PrEP 0.1%. So we also compared the interventions and the human resource that we have on the ground and the program data that we have. Next. So when we were prioritizing our interventions, we also based on the goals model, where we had scenarios. We had 3 scenarios. The first scenario, if it was that if the funding will remain the same, it means we continue with the services as normal. Then we had another scenario whereby we say we are looking at the trend of the funding, and we estimated that the trend of the funding was reducing at 10% per annum. That is from 2024 going downwards. So this goals model was done in 2024 before the executive order. So we were, from our projections, we are saying by 2030, we might have no funding or very reduced funding. So we were looking at the activities, cost effectiveness of the activities that we provide, and how much they contribute to the reduction of HIV. So unfortunately, the 2030 scenario has happened in 2025, whereby we saw the IPs pulling out, leaving the facilities unattended to, and so we had to go by the goals model, whereby we said all activities that are above the red line, it means they are not important and we cannot sustain them. But let's go for the activities that are contributing much to in reduction of HIV. So we opted for the ART, dispensation, PMTCT, and HIV testing. Next. So as I have said earlier on, that our response was based on the goals model that was done in 2024. So we had to redeploy trained Ministry of Health staff to all HIV testing, ART dispensing, and targeted viral load. Human resource was one of the areas that was heavily affected with the pulling out of the partners. So we had to utilize already existing government staff who were trained in HIV services to fill in the gaps. And we also opted for the 6-month ART dispensation to reduce clinic visits and ease the burden on health facilities. And it happened that in some facilities, they had completely stopped working. So we said, no, we shouldn't have expiry of items. So we redistributed some of the items, and we did facility level task shifting, whereby we took in health surveillance assistants. These are community-based, and the hospital attendants to do the mainly HIV testing. These ones were trained some time back, but they stopped offering the services because we had the HIV diagnostic assistants. And we also engaged the private sector, CHAM, and IHAM facilities to absorb ART patients from high volume ART clinics. That is, if necessary. This was communicated to the facilities, even to the drop-in centers, the ones that were closed. And we thought of as another response was that the quarterly data validation that we do at national level, it has to be biannual, and districts have to lead the site level supervision. Next. So going in details on the service delivery, for testing services, HIV testing, we limited it to the antenatal women, inpatients, and the STI clients. I know there are some measures, some populations that were also, that are very critical, but at that time, this is what we opted for. But now we have added VCT on the same. And on elimination of mother-to-child transmission, we said we'll continue provision of prophylaxis to the exposed infants. And we also continued with the testing of HIV-exposed infants at 12 and 24 months using the rapid test. On this one, we stopped the 6 months DBS testing. This is because of the lab systems were affected, and the sample transportation was also affected. So we saw that even if we could take the samples at 6 weeks, it meant that we will have problems in transporting the samples. And again, at the same time, the yield at 6 weeks is very low. So we opted for the 12 and the 24 months. And for STI services, we said we should integrate them in the general clinical OPD operations, and this is done. And again, on the messaging and prevention and condom use, we intensified the messaging in the STI clinics and the condom use. Next. So there were some services that we said we cannot stop, but we should modify. And although some were discontinued at that time, the time that we are coming up with a response, like discontinuing dispensing of ARV emergency refills. This was necessitated because of there was panic refills from the general public. They are saying now that the US government has stopped providing aid to Malawi. It means the ARVs will be out of stock. So they were just coming to the facilities for emergency refills. So we said no refills. And we discontinued oral and injectable PrEP. That was the initial response. But now we have opened up the oral PrEP to all clients and the injectable PrEP for those who are continuing clients, and for the pregnant and breastfeeding women, we have opened up. Then we discontinued the HIV viral load testing. This was because of the same issue of human resource for sample collection and again the transportation. And we had no data clerks to be entering the data in the patient details in the LIMS, the laboratory systems. So we opted for targeted HIV viral testing for patients who is suspected of treatment failure. And we gave in a waiver for facilities that had point of care to continue the testing. Next. So for the progress made so far, of course, there have been some changes in the response, but we are doing ongoing mentorship of staff done by district teams. And the IP partners have also been taught, now that they have resumed work, to work hand in hand with the government staff and do the mentorship, on-job mentorship. And we have resumed the services that were heavily affected, like the testing, sample collection, and the sample transportation. So we are also working on this. We want to build long-term solutions. Once the stop work order was issued, we saw that these were the thematic areas that were greatly affected. So we are working on building sustainable systems so that we don't experience the same in the near future. And now there's restoration of the EMR system that was down in some facilities. This also happened that during the 1 week or 2 weeks that of the stop work order, some of the data was not entered in the EMR system. This was because of relying heavily on their partners. They were the ones who were learning the system. So in some facilities, the system was on, but the providers that were there had no passcode or source code to access the system. And in some facilities, the staff were not conversant with the systems. So they resorted to using manual registers. And on the recipients of care from DICs to government facilities, most of the DICs were closed for some time. So the recipients of care were transferred to government facilities. And this is an ongoing process. Then we did a training needs assessment for all human resource for health in the public facilities, as well as faith-based facilities, even the private sectors. This has been done, and the needs have been submitted to the central level for possible recruitment. Whilst we are waiting for
please, if we can wrap up in a minute, please. Thank you.
Yes, yeah, I'm wrapping up. So we are also doing training for the facilities on the staff who have been redeployed. And we have developed a cooperation framework that has been shared with the implementing partners before they resume work on the conditions of the government. We want services to be government-led. Next. So that is all that we had. Now we have rented beta lesson we are in the process of having all the services and systems led by the government and being managed by government personnel. Thank you so much.
Great. Thank you very much um, for sharing your emergency response plans that I see it's really informed by your goals model. A very good way to go. So thank you very much for that great presentation.
Thank
Our
you.
next presenter is Dr. Andrew Mulwa, head of NASCOP Kenya. Please, over to you.
Thank you very much. Good morning, good afternoon, good evening. I'll quickly take us through the Kenya's response. We go to the next slide. I think as an overview, Kenya's burden of HIV, we have 1.37 people living with HIV. Amongst them, 71,000 or thereabout are children between the ages under the age of 14. And our national preference is 3.3 with a bias on women, having a preference of 4.5% against 2.2 for men. We record about 20,000 deaths, having reduced this from 37,000 deaths per year, but the last 3-4 years stagnated at 20,000 deaths per year. With 58% of the epidemic in 10 counties. Kenya has 47 counties, but the epidemic has geographical bias with the 58% of the HIV epidemic being in 10 counties. And we also have some subpopulations, just like many other places, where commercial sex workers have a prevalence rate of 29.3% for female commercial sex workers, and among us MSMs, 18.2%, and people who inject drugs, 18.3%. Next. As I've mentioned, we have 1.35 million people living on in the country, and of which 47% are children. In terms of financing, 80% of the HIV commodities supply chain is funded by external funding, which is mainly the PEPFAR and the Global Fund. As I've mentioned in the geographical distribution of the pandemic, we have PEPFAR supports 40 of the 47 counties where the epidemic is high, while there are some 7 counties where PEPFAR does not support because of low prevalence of HIV for the last 10 years. In the current budget, in the current year, PEPFAR had allocated $59.3 million to HIV health products, and as a total of 35,000 healthcare workers who are working both in clinical and other program and other support spaces supporting the HIV services. As you can see in the graphs, in the graphs, there has been increasing funding for HIV commodities in Kenya, although this has not been the case in the last 2 years. In the last year, in current year, actually, with 74% of financing coming from external partners. Next. Our mitigation measures are focused on 3 key areas. One of them being the healthcare workers, human resources for health, then the supply chain, which is health products, and the service delivery issues. Next. As part of the coordination, as a part of our response to the stop orders, we actually had a partners or stakeholders meeting attended by all partners at the beginning of the year, where we mapped out priorities that we are working on as the led by the Ministry of Health with the partners, and that actually happened just before the executive orders came in, the week before the executive orders came in. Then we have immediately once the executive orders came in, we have had joint meetings between the Ministry of Health and the National Systemic Disease Control Council, which is the HIV/AIDS Commission in the country, to quickly come up with a contingency plan and appraisal of the situation and address ourselves to matters that required immediate attention. With this, we came up with a document that has been guiding us and the whole ministry in terms of addressing the gaps that would be occasioned by the executive order. We have had also meetings with the Kenya House as a devolved system of government, where the Ministry of Health at national level is charged with policies and setting standards, and the county governments, 47 of them, have the responsibility of implementing those policies and undertaking service delivery. And that therefore, as part of the engagement, we also engage the county governments and their coordination structure, the Council of Governors, to ensure that we take of service delivery interruptions and agree on best practices from county to county. We also had briefs with the senior Ministry of Health leadership and the country leadership to ensure that we all align in terms of agreeing on the priority areas, which I already mentioned, the HRH, the service delivery, and the commodity supply chain. Next. The ministry has also formed a national public health crisis management task force, which is now working on the broader issues around HIV financing, about US government financing, which touches on not just on HIV, but HIV, TB, malaria, reproductive and maternal health, the National Public Health Institute, and as disease surveillance aspects of health service delivery. So one of the major impacts of the executive order was the withdrawal of testing counselors, HIV testing services, which are provided essentially by staff employed by the PEPFAR implementing partners, and that has led to major disruption in the testing services, as well as press services. The press services, especially on the key populations, commercial sex workers, MSMs, and including also harm reduction interventions, what we call the methadone clinics. So the country is also rolling out 3-test algorithm for HIV testing, and we were actually at the tail end of training of healthcare workers to have complete rollout of the 3-test algorithm by the beginning of this month. And that was disrupted because the last cohort of trainings was supposed to happen just before, in the week that the executive orders came in. And that therefore means we had a disruption in the trainings and rollout of the 3-test algorithm. So how have we been able to mitigate? Like I mentioned, Kenya has a high presence and resourcing of health service delivery at the subnational level, and we have been engaging the counties to address issues as per the county needs, because like I already mentioned, that the disease burden is also varied from county to county, and that therefore each county is getting its own response plan based on the burden of disease and the reality of the counties in terms of resources and the facilities and the healthcare workers that are affected. We also have supported the county and sub-county teams to start mentorship on HIV testing services, to other cadres who are employed by the ministry, and we also rolled out the TOT trainer materials as additional guidance to the counties. We are also doing webinars to pass capacity to healthcare workers in the county. We are doing also instruction to all counties to sensitize them on the HIV testing services. Next. So the key populations is one of the services that has been affected, and I mentioned this. And most of the staff working in this space have been sent on unpaid leave and standalone drop-in centers. Some of them have were closed in the initial period, but with the further guidance and new information, some of them are reopening, and staff that are in the front line have been allowed to continue working. Services in the methadone clinics, I have already mentioned, have been affected. And we are also working with the counties to ensure that we deploy relevant staff to continue running this. In terms of mitigation measures, I mentioned that we got a memo that for full integration of the 110 drop-in centers into the healthcare facilities, so that for every drop-in center which is set outside the facility, we link to the nearest facility. And we had we have been having meetings to quantify gaps for full integration of services. And to mention, the country also has had a fair journey towards integration, culminating into integration summit that happened last year in June, and developed a document for integration which has been guiding us, which was launched in December, which has been guiding us in this process. So during the current period, with the waivers that have been coming through, the diocese that are offering ART services are now operational and are continuing to operate. Next.
Okay, Dr. Muller, please, if you can wrap up in a minute. Thank you very much.
Good. Treatment services, I think we have clinical staff, and most of the staff that are employed in the clinical services. We also add challenges, and the county leadership has been engaging the counties. Like I mentioned, where the county burden is less, we have been using the lessons that we have learned in the counties that are not supported by FEP. Go to the next slide. We also are engaging the highest level of leadership in the country, and we have developed a cabinet memo to request or to ask cabinet to approve more resources towards supporting HIV services, which would essentially go to supporting the commodities and human resources for health. Next. In other words, Kenya's plan for sustainability will leverage on the Kenya's UHC. Kenya is implementing a universal health coverage plan through the social health insurance program, and we want to leverage on it to get resources to support the HIV program. Next. That's the last slide. And in other words, we are working on the integration journey, which had begun prior to the stop orders, and we intend to continue the same. However, we need to mobilize more local resources to support the HIV program. Thank you.
Great. Thank you very much, Dr. Mulwa. Finally, we will hear from Dr. Ayisi Ado from Ghana.
Thank you very
National
much.
Program Manager.
Thank you very much, and good day to all of you. So I'll keep it very simple. 32 million people, but our estimated population of people living with HIV is 334,095, and close to 180,000 people on treatment. I have to establish that as far as our national response is concerned, the Ministry of Health is a principal recipient to the Global Fund, and actually co-finances treatment and all this interventions with the Global Fund. PEPFAR supports us through USAID in 3 regions. Next slide. The Western, North, and Al-Hafu regions. And next slide. And it's important to note that the PEPFAR also has a cooperative agreement specifically for laboratory strengthening and strategic information. So I've just listed 10 areas which were affected by the stop order, but not with the same magnitude. For instance, because commodities are not funded by PEPFAR, there was no interruption in supply of commodities. So HIV testing, treatment, and all the viral load commodities, everything was still being supplied. However, aspects of it, like for instance, some viral load monitoring in the 3 regions, and then one work of the ICAP Ghana, which is the USAID NGO, working at facility level to complement the work of Global Fund and the national program in the 13 regions. So things like monitoring and supervision to these 3 regions were halted temporarily. Capacity building, community interventions, quality improvement, data issues, human rights, key population, some recruitments, and commodity distribution to the northern eastern Ashanti region, because there was another USAID program supporting that, and then meetings. But since this happened, next slide, we received the temporary order, what do you call it, the contingency, the waiver. And for the program, we have received permission to continue implementation. So the contingency plan, we have not developed like Malawi, any plan, or Kenya, or anything like that. But immediately this happened, we had meetings with the UNAIDS, and then with the 3 regions, the regional directors in the regions that were affected. And we also had meetings with the civil society groups that were implementing. And we've had meetings with the Global Fund to discuss possibilities of filling the gap. So we were about building the needs. And we managed to collate the needs, escalated it to the Director General and the Minister for Health. On that basis, the President issued a directive to the Finance Minister to find money to fill the gap. Because routine activity is being led by the Ministry of Health program, everything is continuing. It's only the complementary activities that are on hold, like proficiency testing and some of the community-based interventions and key population. But when it even comes to key population, implementation is taking place in all other regions because the principal recipient for key population is funded directly by the Global Fund, not PEPFAR. In addition to all this, I've granted some updates to the media and to different people as part of risk mitigation or communication, because we know, I heard from the Malawi about fear and people coming for refill. We didn't experience that. Having communicated to everybody, there was assurance that there was commodity, and we'll continue to communicate in the meantime. So what has happened is that because we now have the permission to even implement what we are, routinely doing, and some partial waiver for the NGO ICAP Ghana who are working in the 3 regions, we didn't have to develop any contingency plan, but it's very critical as we review the events, because we don't know whether there's going to be a decision will change, as far as this is concerned. But going forward, this is what we think should happen. This is next slide. It's a wake-up call for all of us. And I'm currently in a meeting in Malawi where we are discussing issues of sustainability. And it means that all of us must speed up and complete our sustainability roadmap. Ghana has a roadmap. It's in final draft, and we need to complete and start looking at implementation. We've just had a new government, and we are happy that there is positive response. I've had the opportunity to provide briefing to the presidency, and we're going to advocate for seed money for the AIDS fund. Already, some amount of money had been announced. The president had announced that they were going to find money to fill the gap. So that is positive. And then we will have to look at increased budgetary allocation and domestic funding and ring-fence commodity, some funds for commodity as well. We have to redefine and explore new opportunities and funding opportunities as the way forward. But the good thing and the takeaway from Ghana is that if your program or your ART program or HIV services or interventions are led and owned by the ministry and the government, such shocks come with only little anxiety. So all we have to do is to try to find additional minimal resources to complement the little things that have been, put on hold. But largely, almost everything is actually proceeding as it is. But we are all aware that there is overall potential dwindling of resources for all of us. And this is where our sustainability planning comes in. And we're going to take that seriously, put it in context of this surprise from the stop order, look at all other potential risks. And I believe that when we implement that, we are good to go. If I look, let me refer in my conclusion to the National AIDS Spending Assessment. That information or the last report clearly suggests that the greater part of even funding in Ghana is non-partner sponsorship. So in other words, government of Ghana and the private domestic, support. So already we are shifting the landscape for funding. And what we need to do is to make sure that we shift it further for greater domestic financing, greater leadership and ownership by the Ministry of Health or government, so that we'll be able to absorb such shocks like what happened with COVID-19. Next slide, and I want to thank you all, and I hope I've been able to save all the times that were exceeded by my predecessors. Thank you very much.
Thank you very much, my good friend, Dr. Isiado. And thank you to all our presenters. We've heard from 3 countries with different epidemics and different donor contributions and the extent to which they have been affected and their response measures. What I want to mention quickly before I hand over to my co-moderator is a few things I've heard whilst visiting some countries and talking to other countries. And the fact that in the midst of all of this, some health providers volunteered, even though their salaries were stopped or they were asked to stop work and they knew they were not going to be paid, continued to work, some not receiving anything just to ensure that service delivery continues, some receiving, I'm told, like 50% of their salary and continued to work just to ensure that health services, HIV services remain resilient. And I think I want to shout out to them and to appreciate the work that our health workers are doing in this time to ensure that our programs stay resilient. Oftentimes we have a lot of negative things to say to our workers when we are talking about quality service delivery, but this is an example of how awesome they can be. And I just want to encourage them to continue to do the great things they are doing out there. So with that, I want to hand over to my good friend Peter to take us through the facilitated discussions and Q&A. Peter, over to you.
Great, thanks so much, and thanks to all for the really wonderful presentations, and thanks to the audience for participating and putting so many great questions in the chat. I want to start by introducing our two panelists we haven't heard from yet. Solange Baptiste is the Executive Director of the International Treatment Preparedness Coalition, and Lilian Moekro is the Executive Director of ICWEA, the International Community of Women Living with HIV in Eastern Africa. I'm going to start with the two of them, and just because Solange is on the left side of the screen, I'm going to start with you, Solange. Hearing these rapid responses from the ministries of health, and I'm curious what you know, or what should we know about how communities were engaged in these responses as ministries of health made decisions on which essential HIV services to prioritize, and what do you think could have been done better, or what were some successes and what were some challenges?
Thanks, Peter, and thank you everyone for inviting ITPC to join this wonderful conversation. I was really, I learned a lot from the presentations that came before, and I'm looking forward to an engaging discussion. Look, so I think we have to really remember that community responses are part of the entire picture, and the role of community engagement. I think the CQUIN community is very familiar with the fact that community engagement is not just a dashboard or ticking a box, but it's really truly meaningfully and genuinely partnering with communities to do the work and bring solutions when there are problems. But in particular, now that we're in emergency and a crisis is happening, how can communities be engaged? We know that communities have been cut out, and our own survey with our community advocacy network within CQUIN, the CAN, members have been cut severely for their community work, or their network in particular has been cut from like $30,000 to almost $250,000 per year in certain instances. And I think one of the key issues that we have to consider is the role of community-led monitoring in being able to predictively anticipate where some of the issues are. I know that PEPFAR has invested a lot in our data systems across the continent and in terms of the PEPFAR response. And so there have been periods where countries have been in the dark when they relied on PEPFAR sort of owned data services. And so the importance of community-led monitoring is even underscored then, because you're able to then triangulate data and have sort of an advanced alert system as what is actually going on the ground. Are people being referred? Are services now just not happening when they should happen? Is there overcrowding? How long are people waiting in line? Are they actually getting the multi-month that they need prescriptions? In terms of the role of communities right now, they've been identifying and addressing service disruptions, but we know that these services have been halted sometimes, the CLM activities, so that's now limited their oversight and reducing accountability in service delivery. We know that communities can ensure continuity of care for key populations. In particular, we know that they can be preventing overburdened health facilities, as I talked about just now. And Peter Preco made the point about, the overcrowding and the overburden on health staff. So long waiting times, people being turned away. Community engagement can help to decentralize ART delivery using community-based models, and really helping with preventing unnecessary facility overloads. Support and adherence and retention and care. I don't think any of these things that I'm listing are going to be surprising to anybody on this call, but it's really important for us to remember the role that communities play. They often do it quite silently, and they're a little bit of an afterthought, but really, in terms of supporting adherence and retention, you can think about loss to follow-up cases, declining adherence rates, tracking the so-called defaulters, delivering ART refills, supporting adherence counseling, and then, ensuring equitable prioritization of services. I think in the last 3 weeks, ministries of health, as you would have heard on the call just now in the presentations, had to make rapid decisions about which services to prioritize and how to do more with less again. And if you have limited community engagement due to less funding, the risk is that some vulnerable groups, in particular key populations and rural communities, would are likely to be deprioritized. So having that community voice is critical. And the only other thing I would want to say, Peter, just quickly here is, I know that Dr. Lindley had spoken about, the bitter lesson is that things need to be government owned. And I think Dr. Stephen also reinforced this point about, government owned, government led. I think the other part of that lesson, and it probably goes to the question that was in the chat a while ago about what does an optimized HIV program look like? The other lesson is it needs to be not only government owned and government led, but community driven and data informed. And if we can get that balance right, then I think we can have an optimized HIV program. Thanks.
Thanks so much, Solange. Those are great comments. And I want to move quickly over to Lillian as a recipient of CARE. I think any general comments you might want to make, but the specific question I had for you was a difficult one. In the face of these budgetary constraints, are there any HIV services that can be deprioritized without adversely affecting the essential needs of recipients of CARE? And please, we're just going to give you about 2 minutes, okay? Thanks.
Okay, thank you very much, Peter, and thank you to all our presenters and everybody, and to our governments. We appreciate all the efforts that have been put in place to make sure that service delivery is not constrained within the current situation that we are in. But I want to just begin by saying that it is not about deprioritizing. And I also want to start by, challenging the fact that there's this kind of thinking that there has been the best services that have been given to the recipients of CARE. I think recipients of CARE are human beings, are people, are us. And therefore, what has been given is what probably is a minimum that people needed to have. And therefore, to sit back and think that it was really very, very good is to probably overestimate the situation. And secondly, to say that also for us to think that it was long time and it was needed that the implementing partners that have been giving services needed to go, I think is also an underestimation. So to come back to this question, I think all of us as people, as human beings, as countries, as governments, I think it is important to remember that everybody who's been contributing to service delivery, including the implementing partners that have been told to go back home, including human beings and people that are back home and they don't know what to do, and yet they've been providing a service to us, they deserve to be told, we appreciate you, we love you, you've been there with us when it has been really hard, and therefore they need to hear that. And on behalf of recipients of CARE, I want to shout out to everybody who's been providing services to us that we know what you're going through, we know you've been there with us, and this is a time when we probably need to, stand with you. And again, Peter, having said that, is to say that the services that have been provided for different people, groups of people, categories of people, and people and human beings are not homogeneous. And therefore, to say we deprioritize, it means that certain groups and categories of people and individuals have to be deprioritized. Here we are talking about people living with HIV, we are talking about key populations, we are talking about children, women, men, young people. We are talking about research participants who have also been told they don't know what to do. So there are too many people to be talking about for us to sit here and say, let's deprioritize services. What needs to happen, I think, we have an example of Ghana. We need to probably focus more in terms of how Ghana has taken it. And then we move from that direction in terms of let's engage every stakeholder that has been involved, that has been affected in this. And then we sit down and see how do we use the limited resources that we have to make sure that everybody continues to get the services that they deserve, but also that services are not halted. That would be one. The second point that I think we need to be talking about is countries are moving and faster, especially our ministers of health are running faster in integration. But we need to get back and say, if it is integration that is going to take us where we need to be, how are we talking about in terms of policy, in terms of financing, in terms of governance, and in terms of people, so that we are not integrating and leaving people behind, leaving communities behind, leaving stakeholders that have been holding the response behind. We need to move with everybody, and we need to make sure that the policy is conducive, is favorable, and that the environment is what is needed for us to move to that direction. But importantly, we must talk about money, because it is not, like it is one of the things that is not coming out clearly. We are talking integration, we are talking about reduced services, but we are not talking about money. The point is that there has been money that has been filling the gap, and this money is not there. And therefore, as countries, as people, as citizens of our nations, we need to think around how do we fill the gap, and how do we get the resources that are needed to make sure that services are not interrupted or disrupted. Thank you
Thanks,
very much.
Lillian. Thanks, Lillian. That was a terrific response. I really appreciate your contributions. I want to shift back to the representatives from Ministries of Health. There's been a number of great questions in the chat, or actually in the Q&A box. But I want to ask specifically, I think, to Andrew to see what he thinks of. I'm going to ask you actually to respond to think about Lindley's presentation, where she used or demonstrated how she used data to determine which programs to optimize and how to proceed in this rapidly evolving situation. I'm wondering if Kenya has done something differently. Excuse me, done something similarly.
Thank you. In terms of prioritizing, we have not. Sorry for some noise. I just abandoned. So we have not done. Allowing that.
Oops, Andrew, we're losing you a little bit. Stephen, could I switch to you maybe while Andrew gets his connection back? Or do you have any comments on how to use evidence and data to prioritize your programs as the situation evolves?
Oh yes. The last time we had a meeting on sustainability, I told you that we used the model, the AIDS model with Avenue to help us generate the data to look at efficiency. Now, I shared a matrix where there was analysis to determine the set of activities, all the interventions, and then it was categorized as high impact, high cost, the ones that are low impact, high cost, the ones that are low cost, low impact, low cost, and the ones that are high impact but low cost. Actually, that exercise is being the guide for our roadmap. And some way, somehow, it recommends how the amount of investment you should make in an area to be able to achieve a certain impact. Because we all have global targets to achieve and to end the epidemic. But given the fact that there is constraints of resources, you have to be more efficient, also. So you look at the ones that are of low cost but high impact, and then you complement it also with areas where you can be more efficient and how you can bring innovation beyond the data. Because though the data will tell you that this is where you have to invest, in terms of the processes, you must also use innovation, which may cost less than business as usual. So those are some of the mechanisms that what we can use to be able to prioritize and to make an impact within the limited constraints. Thank you.
Great. Thanks, Stephen. Andrew, are you back? I might ask you a
Yes,
different.
I'm back. Sorry, I lost in connectivity.
No problem. Can I ask you a different question, Andrew? Actually, I'm really interested about the move towards integration in Kenya, and also some of the shifts that your program made to do things more efficiently, frankly, the integration of some of the KP services with the ministries of health and shifting some of the training online and getting more like for the testing. as PEPFAR comes back online, and it probably is going to be a evolving story, which of these shifts and beyond those examples do you think are going to be maintained, and how are you going to hold on to this pathway towards sustainability?
Thank you. One of the key things that we have to sustain is the issue of especially key population programming, which whether PEPFAR comes back or not, we have to integrate with the rest of the services. Then the other things that we want to focus on, and I think for Kenya's epidemic control in the 98, 95, 95, 95 cascade, we are at 98, 98, 98, 94. Our key focus actually is now on the elimination of mother-to-child transmission and pediatric HIV, which are programs that we feel must be integrated. And the integration is not just integrating services, but looking at the whole RAMCA space and ensuring that these services are actually integrated. For us as a country, because we already know our gaps in terms of the 94, the last 94 is mainly as a result of pediatric care. So that is where our focus should be. That is where we want to deploy our resources. That's where we want to make sure that even as we sustain the achievements that we have done over the years, we ensure that we make milestones in the pediatric and age group. Thank you.
Andrew, can you talk just a little more about the plans towards integration and what are some of the practical challenges that you see going forward as you try to move that agenda forward?
Peter, can I talk about that? Can I say
Sure,
something?
sure, Stephen, go ahead.
Right. So integration, about there is a very interesting issue about integration. Practically, it's not everything you can integrate, but one of the things we should be ready for is potential even dilution of services and quality, because trying to integrate into the general stream will be associated with the challenges of the system. But I think it's the way to go, because even with us now working with the Global Fund has introduced the RSSH, the Resilient and Sustainable Systems for Health component of the grant, which is supposed to deal with health systems issues, so that things that affect, let's say, the program that must be dealt with within the health system is taken on board. So we're talking about integration of HIV, family planning services, family health division, family health, maternal neonatal services. All that is something to do. It may not be that easy, because now you are shifting focus from a targeted delivery of interventions, but you need to train more people. Once you have to build the capacity of many people in the health system, it brings with itself challenges with funding. But to address that, we have also launched within the integration innovation of online capacity building. So we introduce e-models, e-learning platforms, which will make it possible for us to bridge the gap in capacity building, which is associated with integrating the service and the need to train, service providers. But I think overall, it's better because there's better ownership of the programmatic activities and interventions by the health system. And with time, the health system finds the resources, leverages other resources to take care, of the programmatic priorities.
Thanks, Stephen. I think it's really important. And the thing I was trying to call out is shifting some of the ways in which we've done business as usual, and maybe for example, moving some of the training programs online might make for some efficiencies where people have access to online services, and then we can make more move this integration agenda more quickly. Lindley, I'd like to bring a question to you. I really admired some of the comments you were making about in the chat about how things are going to look different going forward. Can you talk a little bit about how PEPFAR is showing back up in Malawi and how you plan to work with them going forward?
Okay, thank you. I think that one is directed to me. Hello?
Yes.
Yes, go ahead.
Okay. Malawi, as a country, we have, as Ministry of Health, we have developed a cooperation framework whereby before going back to the facilities, all the implementing partners, including PEPFAR, CDC, and USAID, had a meeting with the Ministry of Health. On that, we were spelling out new guidelines that will guide our engagements, like on human resource, who should take lead, and on service delivery, who should take lead, and even on the equipment and other resources. It was clearly spelled out that the government staff and even the government institutions should take lead of all the activities going forward. So that's how we engaged them. That was at central level, and at subnational level or district level. We advised the implementing partners before going back into the health facilities. They have to meet the district management teams and discuss on how they will be working hand in hand, the partners and the Ministry of Health employees. So they have made work plans at the facility level, ensuring that government personnel are taking lead. And in areas that we don't have government personnel, we have put people on a temporary basis to understudy the IPs whilst we are training our own government staff to do the work with the IPs. We have done this because we don't know what will happen after the 90 days that we have been talking about. So we want to make sure that once the partners move out, there won't be major service disruptions as they have happened now. Over. Thank you.
Thanks, Lindley. Just a follow-up question to that. How are you monitoring the impact of all of these shifts? You mentioned in your presentation about how some of the nurses or some of the staff didn't have the access to the EMR and they shifted to paper registries. And so how are you navigating this, and how will you continue to monitor the impact so that you can make good decisions going forward?
Yeah, just last week you had a team of people going around for spot checks. So we have identified facilities that have problems, and we are working towards that. We are meeting tomorrow to reprioritize and map the way forward with even the IPs now that they have gone back to their workstations. We are continuously monitoring. For sure, it's the entire health systems that has been shaken, and the extent of the impact depends on how big the facility is, how many staff are there, and who is involved in the service delivery. Thank you.
Thanks. And just a question for all of the ministries of health, and this is probably my last question, but I was probably echoing the message Solange and Lillian might want to give is, how are you engaging with communities and to that last question, trying to access CLM data, community-led monitoring data to inform your programming? Any of you can respond.
30 seconds each.
I'll say Stephen first, then Andrew, then Lindley. Stephen, are you there? Okay.
Maybe I can go on to say,
yeah, please.
Kenya, of course, Kenya has a very organized community under what we call NEFAC. And they are part of our national technical working groups, which are the highest decision-making organs in terms of guiding the epidemic. We have already held technical working groups meetings for key thematic areas, the HIV testing and services, for pediatric HIV services, and for care and treatment, which is now the adult program. We feel, and for us in the HIV space, communities are part of our engagement, and that therefore we leverage on the strong network that the Kenyan communities have to not just get data from the community-led monitoring programming, which has been very helpful. Even now, with the now stop work orders, we have been able to work with them the journey, assuring them of the like commodity continuity of services, and even where there are challenges, like when we had problems with especially the KP program, the methadone clinics, they have been able to engage with us, and we have been able to call us and get redress if wherever they are. So the community for us, engagement of communities has been very, very, very important, and the data and information coming from communities is key and integral part of our programming. Thank you.
Thanks, Andrew. And with that, we are at time.
Peter, let me just add.
Yeah.
Nature of our implementation arrangements is such that we are working very closely with the civil society organizations as either IPs or sub-recipients. So our planning to implementation and monitoring, we do it together. We just come from a review meeting. We're all in that meeting. But in addition to this, we have the community scorecard. This is being supported by the French initiative, and it's led by the ministry, the Ghana Health Service. And we have the community implementers as part of this community scorecard. We're doing the training together. The data is being collected together. And that is what I mean when I say that if we work closely with the civil societies embedded, then we leverage the opportunities through the community work. We get the feedback. We've already seen some benefits with this community scorecard already. And I believe that as we continue to collect data, to enhance the national program. Thank you very much. Over.
Great. Thank you all. And Lindley, we made you talk a lot earlier, so we're going to save you from answering this, but I know that the DHA in Malawi has a very close collaboration with your community organizations as well. And I'm going to turn over to Peter Preco now so we can close. We're about 2 minutes over time, and just appreciate again all of the panelists.
Thank you very much, Peter, and thank you, Lillian and Solange and our panelists for a very exciting webinar. I just want to mention quickly that I just want to encourage all the countries to continue to share your memos from your PSs with us. It's really informing other countries on what they can also do. And also, as you develop the SOPs to help implement those memos, also please do share with us so that we can make them available to member countries. As a network, we are also kind of reprioritizing, not to say that other things are not important, but we want to support the way forward for countries. We see that a lot of you are moving towards integration, and of course, the sustainability work we started last year has become more, important at this point. So we want to use our June meeting to focus on integration and sustainability so that we'll have more practical conversations around that, and also to see if we can develop some matrices to help us better define and work towards more matured programs with regards to integration and sustainability. So look forward to those two streams of work. We will be reaching out to you to engage with you on these. With that, I want to say thank you to all of you.
Peter,
and
Peter, sorry, I realized I didn't give Carrie a chance at the end there to comment about the SSLN network. So I wondered if you could just give her a moment.
Sure. Kerry?
Thank you both, Peters. Just to say, I think the SSLN in collaboration with CQUIN, will be supporting and engaging countries. So yeah, thank you for the opportunity. And I guess anyone on this call is welcome to reach out through either network, and we will make sure we collaborate and respond in a unified way so we don't overstretch anybody any further.
Absolutely. And thanks very much for co-hosting this webinar with us, Kerry. We appreciate the partnership. And thank you to all our panelists, and thank you to all our participants, and thank you for joining us. Have a good day.